So good afternoon, welcome. I'm Carlo Di Mario from now Florence. I always make the mistake to say London. It will take another 14 years for me to change probably. And my co-chairman, who is now going to introduce this session, is Professor Patrick Serrais, also from London. And we have so fortunate to have with us as panelists Hitoshi Mitsuo from Japan and Manesh Patel from the United States. We are all interested to hear more about the combined analysis of DEFINE-FLAIR and SWEDEHEART, but there will be much more than this in this session, and I'll let Patrick Serrais to introduce it, please.
Yeah, thank you, Carlo. Very exciting session. As you could see, we will learn about the primary outcome of DEFINE-FLAIR and iFR-SWEDEHEART. We will learn how upcoming iFR study will address physiology guidance in multivessel disease and entire vessel assessment. That will be Adrian Banning, and we will learn how iFR co-registration simplified the complex coronary intervention. Now, I have one slide, which is basically what I have seen in my career. I arrived in Rotterdam in '75. At that time, it was Jung. Before Lens Gould, we had Jung. And it is Lens Gould who introduced that formula where you have the separation of the laminar flow and the friction within the laminar flow. Kirkedy reshaped that a little bit, and then in '91, coming from the Scandinavian country, we got the pressure Y. At that time, Carlo was in Rotterdam. He will remember that we did a lot of work on pressure velocity. We didn't see the beauty of the pressure Y. We did a lot of physiology, and then Carlo and myself said, it's done. We had a few papers, and that's it. And then there was Nico Pels and Bernard de Bruyne, who developed very seriously the FFR. They went to the New England, they validated that very carefully, and for about 20 years it was the credo of the field, the FFR using the adenosine. And very slowly they did this trial in 2001, DEFINE, FAME 2. Then there was an arm who went to Angus, which was the merging of IVUS and angiography. I did that with Cornelis Slager, and then we developed a lot of shear stress. And the shear stress went at a certain point very much developed by Stanford, Charles Taylor, and then suddenly in 2010, we saw, to our surprise, an FFR CT. We were quite surprised. And these people did a family of trial, de facto, next platform, syntax tree. And then, stimulated by these colorful pictures, there have been some company, Medis, P Medical, but also some academic people who still using the Lens Gould formula. So it's a quote-unquote CFD. It's not the Navier-Stokes, it's not the Quemada equation. It's something very different. Developed these technique of color-coded angiography, and some of them want to reduce that to 2D. Some of them want to introduce the fractal flow. We will see what happens. Volcano, Philips is working on that kind of technology. I think that everything is complementary. We can discuss that in the discussion. And then there was one individual, of a few individuals, but one was Justin Davis, destabilizing the whole GOTA of the FFR by introducing the iFR. And I think there was a serious basis. There was a few trial, advice 2. We had the privilege to be the core lab and to review the advice 2. Syntax 2, going to be presented by Adrian Banning, is part of these effort. And then I think that the team did something very well. The team of DEFINE-FLAIR and the team of SWEDEHEART did something well. They jumped from 200, 250, 500 patients to 4,500 patients and go for the trial for the MACE, not juridic discussion about mine is better than yours, but just go for, if you use the IFR of the FFR, you will end up with good clinical of your patient, but the IFR is much easier, is less discomfort for the patient. So we will see there. You have here the name of the speaker. They have basically a short period of time, 15 minutes, all of them, and I hope that we will have good discussion. In the meantime, you could see the title and the speakers. Thank you.
Thank you, Patrick, for setting the stage for this afternoon. And my privilege to introduce the first speaker, Matthias Gottberg, and he will present the primary outcomes from DEFINE-FLAIR and iFR-SWEDEHEART.
So thank you very much. It's a truly pleasure to present the results of these two trials. These are my conflicts of interest. So we know previous to the iFR-SWEDEHEART and DEFINE-FLAIR trials, we did not have any outcome data, but we did have validation trials that showed that iFR had similar or improved ability to detect ischemia compared to FFR. And this is really important because this lays the foundation to the outcome trials. DEFINE-FLAIR is a classic randomized clinical trial. It's a strategy study that comparing IFR and FFR guided revascularization in a real-world clinical decision-making process. We're looking at clinical outcomes, but also symptoms and procedural characteristics and efficiencies. iFR-SWEDEHEART is a registry-based randomized clinical trial. It's still a proper randomized clinical trial. It's just that we use our national quality registries for data input, online randomization, and follow-up. We also added an independent and blinded CA for event adjudication. So what this trial design really does, it facilitates a high enrollment by lowering the threshold for the individual PCI operators to enroll patients in trials, while at the same time we ensure good data quality. Primary hypothesis for both trials was that IFR was non-inferior to FFR for MACE at 1 year. And MACE defined in this trial was all-cause death, non-fatal MI, and unplanned revascularization. So it's a non-inferiority trial and with a non-inferiority margin. Of special note of this is that, let's see if I can get this to work, is that when you're designing a non-inferiority trial, the 95% is usually what have two-sided test, or 97.5% one-sided test should not cross the non-inferiority margin. So it's not the actual results that crosses the margin, but the non-inferiority limit. iFR-SWEDEHEART had a similar non-inferiority margin. One of the questions raised when we presented these trials, well, the non-inferiority margin, is it wide? Could it be 3.2% worse or not? So when we took it into account and look at the upper limit of hazard ratio in contemporary trials, we can actually see that iFR-SWEDEHEART and DEFINE-FLAIR have a very similar restricted margin compared to other large cardiovascular trials. The other thing of note is the components of the primary endpoint. So we knew beforehand that if we randomized mainly intermediate lesions, we would possibly see a difference in classification and possibly a difference in unplanned revascularization rates. Whereas, for instance, if you're looking at trials such as ROCKET, Aristotle, or PROTECT AF, you're looking at death and MI, and stroke mean. So the study design, thank you. The study design was a one-to-one randomization of intermediate lesions, any lesion in stable angina, but in ACS, it was intermediate non-competent lesions that were randomized between FFR or IFR-guided revascularization. And you had to follow the binary cutoff points as defined in previous trials as well. And then we looked at 12-month primary composite outcome. DEFINE-FLAIR was a global trial with 49 sites all across the world. iFR-SWEDEHEART was a Scandinavian trial with a restriction in Scandinavia due to the fact that we have unique personal identifiers and the Scandinavian registry, which allowed us to use the registry-based randomized clinical trial design. And we were doing this trial in 15 sites in 3 countries. DEFINE-FLAIR had a study governance by the Imperial College Trials Unit. So it's a classic ECRF, on-site case record verification, but also a screenshot documentation of iFR and FFR traces in order to ensure quality. And the patients were blinded to the randomization outcome, but also the follow-up team. So it was a double-blinded trial. iFR-SWEDEHEART used a UCR, which is our registry holder, both as a registry holder in itself, but also as a CRO. We perform regular monitoring of SWEDEHEART registry, and we have more than 97% concordance between what we see in the patient healthcare records and in the registries. It's an open-label trial as well. In other words, the patient and the operator were aware of the randomization outcome. And this is how we have to do it if you're doing a registry-based randomized clinical trial. The events were tracked through the registries, but were also assessed by Clinical Events Adjudication Committee. In DEFINE-FLAIR, 2,492 patients were randomized, and in the end, 1,140 and 1,173 patients were eligible for the per protocol analysis. When you do classic randomized clinical trials, quite often you have more stable angina patients compared to ACS because it's always easier to enroll these patients. And this was the case in DEFINE-FLAIR as well. About 80% of patients were in stable angina. Other than that, were very typical patient demographics for clinical trials, and there were no difference between the two groups. Of note was that there was more lesions that were functionally significant in the FFR group. Also, the iFR and FFR value was 0.91 and 0.83 respectively. And this is something that really tells us that this is a clinical distribution. In other words, this is how we want to do physiology. We typically do physiology in a clinical setting today in the cath lab. The primary endpoint showed that iFR had an event rate of 6.8% versus 7% for FFR with a hazard ratio of 0.95, and they fulfilled the non-inferiority criteria. Also, when you look at the individual components of DEFINE-FLAIR, there were no differences whatsoever. One of the things that was noted was there was an excess of cancer death, and that was non-cardiovascular death in the iFR arm. It was not significant by any means, but numerically there were a few more deaths, but not true for cardiovascular mortality. There was also a 10-fold increase in procedural symptoms. The 3% symptoms from the procedure from iFR is just background noise from ischemia when you do balloon inflation or stent placements. Also, more importantly, iFR reduced procedural time by 4.5 minutes. And this is something that also has a true benefit today in terms of cath lab efficiency. In iFR-SWEDEHEART, 2,037 patients were randomized in a 1-to-1 fashion between iFR and FFR. We lost a few patients on each side, either to technical failure or adenosine-related complications. But in the end, no patients were lost to follow-up, and this is one of the strengths of the register-based randomized clinical trials. Also, since we lowered the threshold for inclusion, we also managed to get a higher rate of ACS patients, 38% versus 20% in DEFINE-FLAIR. Also, we evaluated more lesions in the iFR arm than the FFR arm. It seems like we also lowered the threshold when it was easier and less associated with symptoms to do an iFR versus an FFR investigation. But also, we noticed that more lesions were functionally significant in the FFR arm. The distribution of FFR measurements was also a unimodal clinical distribution of FFR values with a mean FFR value of 0.82. Also, more patients, more stents implanted per patient, 1.73 versus 1.58, and this was significant. The primary endpoint showed a 6.7% event rate in the iFR arm versus 6.1% in the FFR arm, with a hazard ratio of 1.12. Also, looking at the individual components of the primary endpoints and other secondary endpoints, there were no differences whatsoever. Of note is that we have very low rates of restenosis and stent thrombosis due to the fact that we have contemporary PCI practice with a very high degree of drug-eluting stents. At the end of the procedure, we asked the patient if they could grade their amount of symptoms on a 4-grade scale from none to severe, and 68.3% of patients in the FFR group told us that they had some form of chest discomfort during the procedure, but at the same time, only 3% in iFR arm, really representing background noise, same as in DEFINE-FLAIR. So there are a few differences between the trials. iFR-SWEDEHEART is an open-label trial, which always works against us when you're having a new experimental design because people have preconceived notion whether it's better or not. DEFINE-FLAIR was a double-blinded double-blinded RCT. We only had 15 sites in 3 countries in iFR-SWEDEHEART, but we enrolled 2,000 patients in almost the same time as in DEFINE-FLAIR, which had 49 sites in 19 countries. In iFR-SWEDEHEART, no patients were lost to follow-up. In DEFINE-FLAIR, 166 patients were lost to follow-up, but at the same time, this is very common if you have a global trial to lose this amount of patients. A few other differences. More lesions in the iFR were evaluated due to lower threshold, but this was not seen in the DEFINE-FLAIR group. A little bit more ACS, as I mentioned before. We did not detect a significant difference in procedural time. Numerically, there was a shorter procedural time in the iFR arm in iFR-SWEDEHEART, but it did not reach statistical significance. We did have an incomplete data set for this, and also since we had more lesions evaluated in iFR, this may have blunted the significance. But there were also similarities between the trials. Very similar non-inferiority limit, and the differences between 3.2 and 3.4% has to do that we had differences in our calculation on the expected event rate. So if you look at the upper hazard ratio, it's the same. There's also a significant reduction in discomfort from the procedure in the iFR arm. More stents were implanted in the FFR arm in the iFR-SWEDEHEART, higher revascularization rate per patient, in other words, in the FFR arm, but very concordant results showing that iFR was non-inferior in both trials. So if you combine the 2 data sets, which we recently did, and Javier presented this at the late breakers, we see that it's very much non-inferior. 6.47% in the iFR arm, 6.41 in the FFR arm, and 1.03 in hazard ratio with an upper limit of 1.31. So the MACE is very similar and it's very low. So we can say it's safe to use either iFR or FFR in this setting. So my conclusion is iFR is non-inferior to FFR regarding the MACE as described at 12 months. iFR improves patient experience significantly by reducing the discomfort during the procedure. iFR also offers an improved procedure safety. We have a shorter procedure. In the aftermath of iFR-SWEDEHEART and DEFINE-FLAIR, we also have an editorial in New England Journal of Medicine, and Deepa Bak's comments was that FFR has been the evidence-based standard for invasive evaluation of such lesions, but now it appears that iFR may be the new standard based on these 2 trials and the concordance of data. And also, very quickly we managed to get this into the new appropriate use criteria for coronary revascularizations in patients with stable ischemic heart disease, which I'm very happy for. So this is truly collaborative work, and we're very happy to be along the way, have a very good collaboration between Justin Davis, Javier, and myself. But also among all the participating centers investigators in these 2 trials, it's truly been a huge effort to include this number of patients in a short period of time. A special acknowledgement to these people as well. And both these trials were published in New England Journal of Medicine, and I think that gives us a great strength to saying about the non-inferiority of iFR versus FFR. Thank you very much.
Yeah. Okay, I think that was a great talk, and certainly there will be a question. If I can open the debate, if there is debate. I think it was a wonderful medical coup to have these 2 trials together, not to say mediatic coup, but a good medical coup. And I think it will have immediately a major impact on the guideline because you're coming there with substantial number of patients. The question that I have heard many times is that, I'm working by memory, the functional significant type of lesion in the iFR was, I think, 29%, and something like 36 in the FFR. So one way or the other, some people said, hey, they detect less lesion functional. And some of them has asked, how long will the people be followed? Do you have the potential risk that these two curves, which are strictly superimposed, with time diverge? That's what I've heard, and I think that the audience want to hear your answer. I know your answer, but please tell them.
Well, I try to be reasonably brief. When we're comparing two indices against each other, for this trial, of course, we set FFR as the gold standard in terms of this being the comparator. But one of the problems when you're looking at different indices of ischemia is that we know that FFR is not a perfect index of ischemia. When we are comparing FFR with other indices, it doesn't have a perfect correlation. So that we need to take this into mind. Yes, we did have a slight difference in classification, but that has, if you look back at the different other trials, when you look at it, for instance, the comparison between pressure and flow, we know that iFR has a closer correlation with flow than FFR has. A special note is that a special subgroup in intermediate lesions will have very high degree of flow. In other words, they're very responsive to adenosine, so they can have a CFR, coronary flow reserve, of 3 or 4, but this makes the FFR to become significant because you get a pressure gradient, but you have a very high flow. And it's been a number of publications actually showing this before. So I think that I would sway it the other way around. I think that because iFR is more closely related to flow, we might actually be avoiding overtreatment of certain lesions.
I feel that Manel want to ask a question.
Maybe I'll ask a couple that I hear all the time also, just to get some points. You spent some time talking about non-inferiority, but now that we have the trial results, do we even need to worry about non-inferiority? The trial results are superimposable. So what is our confidence now? You know, at the start of any trial, you have to plan it, but now we have results. So what would you say to those out there that say, well, you know, the trial was designed with too wide a margin?
Well, I mean, first of all, like showed in one of my slides, the confidence interval margin was not too wide when you look at other trials as well. With that said, yes, of course, you need to have a certain margin of uncertainty when you're doing non-inferiority testing, because otherwise you would have an infinite number of patients. But to be honest, we have now 4,500 patients in this physiology trial. So I think that just the wealth of data showing non-inferiority is enough. And if you have a hazard ratio of 1.03 with the combined results, then of course a non-inferiority limit becomes irrelevant.
And just the second question, which is around deferred patients, and then there may be a question here too. Tell me about deferred patients and what we know from the trials about patients who are deferred.
Javier presented data, I didn't present it right now. Javier presented data on the deferred patients, and of note that was, of course, if you have an ACS, you have a inherently higher risk if you defer patients. There were no significant differences between iFR and FFR per se, but what was observed is that when we looked at the deferred patients and split the categories, stable angina versus ACS, we couldn't detect any differences in event rates between stable angina and ACS in the iFR investigated patients. But in the FFR investigated patients, we did see that the curves separated a little bit, which is borderline significant, to be honest. So I think that this finding needs to be taken into account with a little bit of cautioning. But at the same time, it fits the model that in ACS patients, you have a higher degree of microvascular resistance, which may blunt some of the adenosine response as well. So I think we should interpret this finding a little bit cautious.
I think there is a question here. Yeah? Otherwise, come here.
Now, you told me that this deferral rate is different because of the discordance between flow and FFR. I think it's true, of course, but can't we just give it more proof by looking at LED versus non-LED? If this is true, you would have more deferral at LED than in non-LED lesions, because flow is higher there. Can you show this by your data, firstly? And if true, what are the implications for the left main? Because there the problem is still higher, and it was an exclusion criterion in both studies.
It's a very good question, and yes, we do have have the ability to retractodate and analyze this. I don't think that it will be any difference because I don't think that there's any huge discordance between different vessels. Yes, of course, you have a higher degree of flow in the LED, but the ratio should still be the same. The microvascular resistance should still be the same for the different territories as well. So at the top of my heart, I don't think there will be seeing any difference between different vessels.
I have a super short remark as well. I mean, this was a trial that was done in the centers with the greatest use of these physiology techniques. You show a difference in time between iFR and FFR group of 4.5 minutes, mainly data coming for DEFINE-FLAIR. I mean, they already know that the patient will have a physiology assessment, so they are somehow ready and prepared. And is a little bit more than the 2-3 minutes required just to have the adenosine running. But in reality, if you do an FFR in your lab, you have to ask the nurse to get out of the cupboard the drug and prepare. And I mean, I think it's not realistic. And administrators will value this time lost much more than the patient's symptoms, unfortunately.
I think you have a fair point. When looking at this, of course, we knew that it's going to be physiology in these patients, and most of the sites who enrolled in these trials were obviously physiology users, which meant that the threshold of doing FFR is lower compared to a site that does not do much physiology. So yes, I think that's something that needs to be taken into account.
Oh yeah. Gabriel, the last question, because we have to move after that.
No, I think that the comment of the left main is an excellent comment. I think that is very important, but we have to remember that the evidence that we have about FFR and left main is telling us that if you defer patients that have a normal FFR, you are doing the right thing. So it's not telling us if some of the patients in whom surgery was indicated or CABG actually had stenosis that were not significant. So in those studies that you see that we have supporting the use of FFR, it may well happen that some of the patients were sent to surgery without need.
Okay, that was a good comment. You want to introduce the next speaker, or if I do that?
Please, Patrick.
Okay, I'll do. So it's a pleasure to call upon Professor Adriaan Banning from Oxford, implementing physiology and imaging to improve outcome in the management of multivessel disease, what to expect from SYNTAX 2.
Thank you very much, Patrick, and it's my pleasure to present some further information about SYNTAX 2 on behalf of my co-investigators in the room, Professor Sorois and Javier Esquenet. SYNTAX trial was a fantastic trial, but it's worth mentioning and repeating that actually it was only 900 patients that got stents. There must have now almost been 900 publications, one publication per patient, since that trial was done.
We have done better.
We know the overall outcome. The overall outcome was that using the technology at the time, coronary artery bypass surgery had better outcomes. We have to remember that this was done an awful long time ago. In 2004, it was dreamt up. The procedures began in 2005. Initial data was presented in 2008. This is nearly 10 years ago. Importantly, when we look at the data, I'd ask you to concentrate on the 30-day outcome. In the gold bar is the outcome with the Taxa stent. 2.2% death at 30 days. How many of you, as interventionists in the room, have a 2.2% death rate at 30 days? If you have, the door is just over there. So this was an extraordinary trial, and an awful lot of stents were put in single sittings, up to 14 stents at one go in the SYNTAX trial 10 years ago, with the Taxus Express stent, which was very stiff and difficult to get in. A mean stent length of 86 and 4.6 stents per patient. So when we look at SYNTAX, perhaps 10 years on a bit more critically, it was a uniquely high-risk population for this randomized trial. And I would argue it compares, perhaps for a number of wrong reasons, exceptional PCI with what was routine, excellent coronary artery bypass surgery with very high rates of arterial revascularization. We demonstrated that actually we could only do so much in those days with single-sitting revascularisation, and we left an awful lot of CTOs. Incomplete revascularisation was arguably the norm, and perhaps we didn't spend enough time optimising the stents that we put in. Importantly, this trial was based on angiographic assessment rather than functional assessment. We decided beforehand where we're going to put the stents, there, and then we did our best to do it. And the stent, as I've said, that we were using was an old-fashioned one. And it's notable that the more stents you put in, the worse your outcome was. So things have moved on. We have better stents. We now have pressure wire, and the graph on the right-hand side there shows the data that we're all familiar with FAME, that actually using physiological assessment, we can get better outcomes using less stents. We've moved on with our strategy, particularly using radial angioplasty. We have better drugs, ticagrelor, prasugrel. We need ReoPro less often. We certainly have less stent thrombosis because of the stents that we use and because of the technique that we employ. And we're certainly very much better at CTO. So 10 years on, can we do better? We now have better stents. I believe we have a better strategy. And I think using more scrupulous technique, particularly using imaging, we can make sure that we've done a better job. Are our stents really better? Well, here's some data, 5-year results of a randomized comparison of Xience against paclitaxel. And in this trial, we saw differences in TVF, TLF, ischemia, and actually even death when we looked at Xience versus Taxus. The Synergy stent is a thin stent with abluminal coating. It's radiopaque, so you can actually make sure that when you do your post-dilatation, it's accurately placed and you're not damaging areas of normal vessel. And this stent, we believe, is a significant step forward compared to Taxus Express. What about iFR? Well, I'm not going to repeat the FAME data again. We know that actually by using physiology, we can get better outcomes with less stents. And in the context of multivessel disease, in the left-hand panel, if we look at 3-vessel disease based on the angiogram, this is the distribution of the syntax score. But by using physiology, that's reclassified in up to a third of patients. And ultimately, some of those lesions don't need to be treated if they're not flow limiting. Intravascular ultrasound, we know it improves outcome. And in this trial, we used intravascular ultrasound to ensure that we treated the right bit of the lesion, that we hadn't left areas of vessel uncovered with geographic miss. And we made sure that we used optimal deployment using modified music criteria. So this is the set out of the trial. Patients were entered based on the angiogram. They underwent heart team discussion based on the Syntax 2 score, and I'm going to discuss that with you very briefly in a moment. And if the patient came out with equipoise, so that either bypass surgery or angioplasty was possible, the patient was offered stents. And that registry data that we obtain will then be compared with the angiographic arm with the PCI arm of the Syntax trial. So on the right-hand panel here are 3 possible patients who went through the algorithm. The first patient at the top there has an anatomical syntax score of 48 and is a 74-year-old patient. And as you see, the 4-year predicted mortality with angioplasty is 33, the 4-year predicted mortality for bypass surgery is 6. Consequently, that patient would get bypass surgery. In the second panel in the middle, this patient has an angiographic syntax score of 16, but importantly has airways disease. And angioplasty as a consequence comes out as having a better likely outcome than surgery. The third panel is the sort of patient that would be allocated in the trial, where with an anatomical syntax score of 20 in a relatively young patient with normal kidneys, normal ejection fraction, no left main disease and male, there is equipoise between angioplasty and surgery, and that patient would be offered into the trial, where treatment would be undertaken according to this protocol. If iFR was less than 0.86 down the left side of the panel here, then treatment was undertaken with Synergy stents. Those Synergy stents were optimized with intravascular ultrasound, and medical therapy was pursued thereafter. In patients where the iFR was clearly negative, 0.93, no stent was implanted in that lesion, and we went on to the next lesion, In this hybrid protocol, where the iFR was between 0.86 and 0.93, and importantly, this trial was designed before we had this definitive data from the 2 trials we've heard about, FFR was undertaken, and patients were allocated according to the FFR. So you see in this patient here, on the left-hand panel, an angiogram which has certainly required stents within the Syntax trial. The iFR was 0.95. This lesion was deferred. But significant disease in both LED and circumflex was treated based on ischemia detected by the iFR. 2 stents were placed in the circumflex with this result, and we went on to treat the LAD. We placed 2 Synergy stents in the LAD, with this result here. Now, importantly, this is one of the differentiations, I think, with Syntax 2. We then went on to do intravascular ultrasound. And you could see just perhaps on that angiogram, there was a bit of a nip at the ostium of the circumflex, and that was confirmed by the intravascular ultrasound. We hadn't done as good a job as we thought we should have done. And so we went on to place further stents, pot, kissing balloon, further IVUS, make sure we've done a good job achieving this result. And we hope that this stringency of performance will mean that we get good, if not excellent, long-term results in the future. This second case, I think, illustrates how we have moved on. So this patient has a right coronary stenosis that you can see, some disease of the circumflex in the left panel, but also occlusion of the LAD, which initially we thought was relatively short and perhaps relatively easy to get across. It wasn't. We couldn't. But we went on to treat the right coronary lesion with stents, as you see, with an excellent angiographic result, and consequently went on to use a retrograde approach through the right coronary stents that we deployed, taking acceptable collateral to get access to the LAD, and then a retrograde approach using an RG3 wire, and ultimately performing antegrade angioplasty and then stenting. Synergy stents with an excellent angiographic result. But importantly, once again, it's still not quite over. You've then got to do the intravascular ultrasound, and then you see that actually, although on the angiogram it looked great, there are areas where this stent is not properly expanded, despite post-dilatation with a 3.5 balloon just there, and you've got to go back and do it again until the result looks good. It ain't over till it's over. This is the result that we got, and we hope again that this level of stringency within the study will be beneficial. So we had 20 participating sites, many of them in the UK and Spain, and the trial is now completed. We completed the trial in January last year, and we look forward to the data going forward. As I've explained, what we're going to do is to compare the outcomes within these newly recruited patients who've undergone stenting with the data that we have from the Syntax 1 trial. And these are the data that we have already. In the blue on the left-hand side there is the Syntax score 2 for the angioplasty patients within the Syntax trial. And it's reassuring to see the match with the new patients that we've recruited. Similarly, the coronary artery bypass surgery patients are also matched along with the predicted mortality that we would have expected. So that the way in which you've selected these patients seems to have been successful in generating a patient cohort that we can now follow. Their age, sex distribution, presence of diabetes, smoking, MI, previous stroke, hypertension are all similar. The angiographic Syntax score is very similar, and the distribution of their clinical presentations is similar with similar ejection fraction of the left ventricular function. When we look at the number of lesions, 4.3 in the old Syntax versus 4.2, but as you might anticipate, the requirement for treatment is much less in the new trial, only 2.6 versus 3.2. Similar numbers of stents, but actually longer stent length, and the total stent length is definitely longer in this trial. A very high penetration of intravascular ultrasound, 96.6, which is almost unparalleled in this complexity of disease. And so we look forward to seeing whether that stringency, based on imaging and making sure that our stent results are optimal, bears dividend with regard to clinical outcomes. These data set out the way in which iFR was performed within the trial, and you'll see that a number of cases, despite us using this hybrid approach, the requirement for adenosine was actually quite small. That we only required adenosine in a minority of cases, and in a total of 73% of cases, the lesions could be assessed with iFR alone. So even using a hybrid approach, adenosine was rarely required. And consequently, when we look at that in a pie chart, we see that in 75% of cases we did the treatment and we were successful. 23% it was deferred, but complete revascularization seems to have been the norm. We did not fail on many CTOs. We were successful in achieving complete revascularization, and that's exciting going forward with regard to what that may mean for our patients. So in conclusion, compared with the initial Syntax trial, we've shown in this new study that less lesions would needed to be treated as a result of our functional assessment. We've benefited from the availability of more flexible, longer stents and the mechanical properties of the Synergy stent. But we've made sure that we managed to cover that lesion, or those lesions, more efficaciously, and perhaps as a consequence we have longer stents. But I do believe we have more complete revascularization. And as a consequence of that, we were able to benefit from using staged PCI. Staged PCI is not a sign of weakness. Staged PCI is a sign that we're making sure we do the job properly. And most patients, if you offer them the opportunity of having the job done properly over 2 procedures or rushed and bodged over 1, would certainly take the initial option, I suspect. We believe that we've shown using iFR and IVUS that this study has already shown better procedural results, and we look forward to the final results which will be presented at Barcelona this summer at the European Cardiac Society. Thank you very much.
So this paper is now open for discussion. Maybe while people prepare themselves. I mean, obviously, the final outcome will be somehow a comparison with both the arm treated with the conventional Taxus stent in 2000 and the report in 2008, and more importantly, a matched series of the surgical group. And I can already see the commentator coming the ESC to the podium to say, well, of course, in 10 years, surgery has done enormous progress as much as interventional cardiology. Most of what he is going to say is nonsense, but there is an obvious point that has to be considered. This is guided, so you treat only the vessels that are physiologically relevant. And nowadays, in general, we tend to give the surgeons this information most of the time so that they can also avoid placing useless grafts onto a 50% right coronary artery lesion. How do you answer this question?
So I think there are 2 points there. The first point is, have the surgeons moved forward in the last 10 years? Not much in Oxford. In fact, I would say what we had in Syntax 1 was exceptional surgery with a very high rate of arterial usage and really very good outcomes. And that actually doesn't reflect what 95% of patients get in the UK when they go in for a lemur and 2 veins. So I think that that's a problem, because I think excellent surgery in
Syntax... If I can
Syntax...
support what you say, is that in the Syntax 1 there was 26% of beta. In the Excel is 28%, so 2% in 10 years is not so much progress.
Yeah. So I think, you know, we truly went into very high-performing surgical centres in Syntax 1. The second point, remind me, Carlo, what was the second point?
Was the use of physiology to decide which vessel to
and I think that's a really good point. But of course, once you cross the threshold into physiology, you then look at all the data that we've got and you start to think, oh, hang on, that wasn't physiologically, and all of a sudden it all starts to fall to bits a little bit, because we actually really need to reconsider an awful lot of what we've done. And I think it's an important point. I think we have moved forward with regard to our understanding. And of course, we do understand better why 1/5 of the grafts were blocked at 6 months, you know, and it was asymptomatic in many of those graft occlusions in the Syntax trial, because ultimately, when we looked at the angiographic follow-up of Syntax in Le Mans, there was an awful lot of blocked grafts, but the patient didn't have that many symptoms. Those lesions were presumably not ischemic, otherwise we would have known about it. It's different in Excel, where we saw catastrophic graft failure in patients presenting, therefore, with procedural infarction. So I think we do have to look at all of our data again and reconsider everything based on physiology. That ischemia is the enemy, and revascularisation is the solution. And we should start off from that again and take everything as it comes. It may mean that we've got to do some of these trials again. But ultimately, I don't think we can kind of look back, because we didn't know much stuff then, and therefore it must have been right. We now know more, and we've just got to go forward.
Let me ask one question.
Yeah, please.
So treating the multivessel disease by PCI, we have to think about the dose of the contrast. Did you check any difference between the PCI control arms and this Syntax 2?
So I can tell you our data. I can tell you our data in Oxford, because I've done that. I haven't got the slide to show you, but we looked at the procedural times for Syntax, Excel, and Syntax 2. Interestingly, in Syntax 2 compared to Syntax 1, we used less contrast but took longer. Why was that? Because we were doing intravascular ultrasound. And we were doing, I'm afraid, crash, bang, wallop. I mean, that's what we were trying to do in Syntax. We were using, it was not the sort of intervention that I was doing in 2005, where I set out, right, 3 vessels, 5 stents, here we go. And, you know, and that's what we had to do. So I think a more, and I think the, you know, as I've said, the staging of procedures was actively discouraged then. It is now, and within Syntax 2, it is a reasonable thing to do. And so we haven't really got a problem, I think, with contrast nephropathy. I think ultimately we've learned, and again, we're going to hear a little bit about how iFR in particular can tell you where the lesion is more accurately, and to be sure that you're treating the segment which you need to treat. Now, whether you do that with IVUS before or whether you do it with iFR, what we do know is that the angiogram is not necessarily the best guide. And I think thinking about that is one step forward. So contrast has not been a problem. Patrick?
You are an influent key opinion leaders. So what would be your advice to Volcano for the next trial?
What would be my advice to Volcano for the next trial? It would be do
I
it.
caught him off guard.
I think the trial that you've designed using CT is valuable.
Yes, yeah.
I think that is important. I think where we go next is to do, as I've kind of hinted at really, which is to look at all the data again and say, well, actually, what does this mean and what doesn't that mean? I hope that this gives us a leg forward. And for me, the next trial is to do a big randomized trial again, using physiology, using optimized outcomes, and really design a trial probably where we go head-to-head with the surgeons again, using what we now have as contemporary technique against a cardiac surgical.
Exploring the main stem, you know, in Excel there is only 10% of FFR, and we are still nowhere in the so-called Medina 111 of the main stem. What is your
I think
opinion
one of the
on
differences, I mean, perhaps I'll answer your question with slightly tangentially. The difference between Excel with a really fairly clear protocol, clear management guideline, you must do this, you must do this, you must do this, compared to Noble where it was a bit less clear and you can do what you want but try and get a good result. For me, it doesn't surprise me that with careful attention to the left main, trying to avoid second stent if you can. You know, I think once again, it took us quite a while as interventional cardiologists to get over the fact that 5 stents are not as good as 3 sometimes. It kind of hurt because we kind of believed the more stents it was, the better it was. But when we come to bifurcation treatment, particularly in the main, if we can get away with 1 stent which is properly deployed and we're not compromised the branch, that is the best result for the patient. It's safer and actually it's symptomatically equivalent. And I think that's pretty much what we need to go forward. I think we need to be thinking about careful bifurcation technique, particularly in the main, and how we make sure our stents are properly deployed. And I think that scrupulous technique going forward, where we've moved away from the best cardiologist is the guy who puts the most stents in the fastest.
I have one question about the trial, and you may or may not have this data. Are the patients that are going to bypass surgery, do they have physiology?
All right, so this trial is a investigator-initiated trial. So we have not got, it's a registry essentially, where we're going to compare the Syntax 2 patient cohort with a historic surgical cohort in Syntax trial. So there is no newly recruited surgical arm in this trial.
So the patients who at the heart team that go to bypass, they are not followed, and we don't know the physiology in those patients?
Correct.
Okay.
Still a question?
Until we reach ESC in Barcelona, in the meantime, if you have a patient that has a Syntax score of, let's say, 38, not diabetic, you assess the lesion and you bring this Syntax score to a functional Syntax score of 20, do you feel that it's an appropriate evaluation to downgrade this patient from a potentially better served bypass patient into a PCI patient?
There's a great graph from the Syntax trial looking at the outcomes in various centres. And it looks at how some centres had fantastic results with surgery, some centres had fantastic results with angioplasty, some centres had less good results with one or the other. I think it depends very much on the patient. let's imagine that 20 is an LAD occlusion. Let's imagine that 20 is a very long segment of LAD in a diabetic. Well, I wouldn't downgrade that because the right coronary is a bit of a dink and it actually didn't need doing. I'd say the patient needs surgery. And so I think you have to look at what is the best thing for the patient in the round. And I don't think necessarily, I think scores are great, but everything's about that individual patient. And I think what we have to offer that patient is also dependent on them as an individual. So I would personally not get too carried away with a score and keep it in the patient.
So, thank you very much, Adrian.
Yeah.
Let's move to the next speaker. So, precision medicine is the leitmotif in all fields, not only cardiology. Increasing precision of coronary stenosis assessment using iFR. This is the topic of Justin Davis from Imperial College London.
Thanks very much, Carlo, Patrick, and good afternoon, everyone. So I'm going to base this talk really around the data, some of which Matthias shared with us earlier, and also around some of which was presented by Javier Escanad yesterday, and then really bridge that into the next talk, which Javier is going to speak to you with regards to co-registration and systematic assessment, and really kind of to show how I think it's possible to move beyond assessing an individual artery to actually where in the artery potentially we could be treating, or as Adrian said, potentially deferring. So we know if we look at the trial data we have so far, and this is data from the DEFINE-FLAIR study, which was presented at the ACC meeting, that there is, in the iFR arm, fewer patients receiving treatment with either bypass or PCI in comparison to FFR. Now, this wouldn't count for anything if the results for these two different revascularization strategies weren't almost superimposable. And you can see here from the DEFINE-FLAIR study, as you saw Matthias present a few minutes ago, that the MACE rates from FFR and iFR guided revascularization strategies are indeed superimposable. We know that it's possible to expand the power of our analysis even further by combining the DEFINE-FLAIR and SWEDEHEART studies into a much larger study. This slide, which Javier presented yesterday, the late-breaking trial, shows you how we've moved from a study defer of 90 patients performed over 20 years ago, FAME performed more recently with 500 patients in the physiology arm, to much more larger studies and in contemporary patients with 4,500 patients. So the game has really moved on hugely, and it enables us to assess very carefully how precisely we can guide therapy in these patients. Now, this study showed much the same for the combined patient population of DEFINE-FLAIR and iFR-SWEDEHEART in both ACS and stable patients combined. You can see once again here that more patients were deferred using iFR than FFR by about 5% more. Again, raises this question, are we inappropriately deferring, or potentially are we more precisely selecting the patients who should receive treatment? You've heard Matthias address this by saying that because iFR is more closely linked to flow, and we know the outcomes are very good if you do guide therapy by flow, that potentially this could be a huge advantage of iFR. You heard Adrian mention shortly before that one of the big advantages of interventional cardiology over the last 20 years or so has been this notion of moving from 5 stents as quick as you can deploy them to more focused PCI. So potentially fewer, better targeted stents could be an advantage. These are the results that Javier presented yesterday. I think they're pretty impressive, showing in 4,500 patients, MACE rates for iFR and FFR guided therapy, which were superimposable, hazard ratio of 1.03, and of course this is very non-significant, and shows you whichever one of these modalities you choose to guide your therapy, you get very similar results. And of course, remember, you're putting fewer stents and putting fewer patients through bypass surgery with iFR here than FFR. So it does raise this very interesting question, are we doing more procedures with the FFR than we actually need to do? Now, one of the things we focused in on this latest work presented yesterday was this question of deferral. How safe is it to defer? And this has really been the question over the last 3 or 4 years with regards to implementing a new technology. People ask, you say, is it safe? If the iFR is 0.9, is it safe to defer? Or should we refer to the FFR? Well, I think this has been addressed in for both IFR and FFR really in a very unequivocal way yesterday in this study. So looking at 4,500 patients deferring according to single cut points, and we see whichever modality you choose to use, that the event rates are very, very low in those patients who are deferred. Now, the event rates here are about half of what they were in deferred patients in the deferred study. So that shows you both the progress of interventional cardiology and also perhaps the decision-making that we've learnt over the last 20 years or so from many of the studies you've heard spoken about even in this session. Now, the other really interesting thing, which of course interests us as interventionalists because we have an increasing body of patients coming and presenting with acute coronary syndromes, is how can we use these tools, physiologically guided revascularization, which we know have been proven with regards to MACE in stable disease in patients presenting with acute coronary syndromes. This is a very interesting ongoing question. And the reason it's interesting is because we know the physiology in acute coronary syndromes is not the same as in stable disease. Notably, we know that in acute coronary syndromes, it's possible, due to the microcirculation being filled with gunk from atheroma and a ruptured plaque, that the effects of a hyperemic agent such as adenosine are muted. And what this means is you don't have the big response in blood flow that you'd expect, and you could have an underestimation of lesion significance. And this is an FFR-related issue where you need to drive high levels of flow to make the assessment properly. So this graph here shows you in the patients that were treated with ACS and stable coronary disease, what were the differences? And we see they're basically the same. So this is independent of the techniques we use. We basically see that ACS and stable coronary disease have an event rate between 8.5 and 8.7. So that's very reassuring. Now, what's interesting, and perhaps not surprising, we've seen similar graphs to this before, is that patients with ACS have higher event rates if they're deferred. And we can see this graph here, again, which Javier presented yesterday, shows that there's a significant difference. Again, this is combining both IFR and FFR guidance here when you look at stable disease or acute coronary syndromes. So you see the people with ACS who are deferred appear to be doing worse, significantly worse than those with stable coronary artery disease. So this raised a very interesting question, and a hypothesis which we addressed in this data and then presented yesterday was, well, we know there are these potential doubts with FFR with regards to blunting of hyperemia. Potentially those are not limitations seen in IFR, but could we test this and divide this analysis into these two groups and look at this? And this is what Javier presented yesterday. So patients who have FFR guidance presenting with acute coronary syndrome have a 6.4% MACE rate, as opposed to those with stable disease of 3.4%. So about 3% higher MACE rate, hazard ratio 0.52, which is significant, with a threshold less than 0.05. Whereas if a patient comes in with ACS and they're guided via an IFR guided therapy, the event rate is 5.4, and the stable coronary disease rate is 3.8. So this difference is smaller. Hazard ratio here is 0.74, and it's non-significant, this difference. So the conclusion here is in FFR deferred patients, MACE is significantly higher in ACS than stable coronary disease, whereas in IFR deferred patients, MACE was smaller in ACS and stable coronary artery disease. So it appears potentially that this mechanism, which has been widely discussed with regards to blunting of the hyperemic response, can actually now be seen in hard clinical endpoints with MACE. Now, this study does not stand alone. There's 2 or 3 studies, including famous NSTEMI study, which was which reported a couple of years ago at the ESC, and others, which show similar things. The key difference here is that by having a non-hyperemic arm, such as the IFR, you can expose the difference. It's not per se the fact that it's an ACS, it's a fact that you're not, it's a combination of both ACS and the fact you're not driving hyperemia to that extent that you need to make this diagnosis, and you're effectively deferring more lesions here with FFR. I'm going to stress this point because I think it's very important that these studies are performed in the distribution of which patients are actually being brought into the cath lab. So most of the patients we come into the cath lab have FFR values which are close to the FFR cut point of 0.80, so typically around 0.81 to 0.83. And this is exactly what we've seen in DEFINE-FLAIR, we saw it in iFR-SWEDEHEART, and you can see in these other studies from centres and groups all around the world, that's very, very consistent. This is the first data we've really got in this intermediate zone. It's the first data where we can actually see how safe is it to defer IFR, how safe is it even to defer FFR because everyone is stacked in this intermediate zone. So I think it's very important. And you can see here it differs hugely from the mean values that you got from FAME and DEFINE. I'm really going to move on just to the next phase, really, I think, of where we're going in this journey with regards to how we would treat and manage different patients. Here you've got patients with different levels of coronary artery disease, and these patients could be managed in very, very different ways according to individual preference, physiology, IVUS, however you want to think about it. But I think that to think about things in a simple red-green treat, don't treat approach using the angiogram alone is ill-advised now with the data we have and the evidence which has been building. So what I mean by that is if the FFR or IFR is greater than 0.89, then you just don't treat. And if it's less than that, well, just go ahead and put stents in. Surely there's more to it than just that. And I think these two curves give you some of the information which would attest to that. So namely, you can have very positive IFR results in this case here, but these two patients are very different. The one on the left side of your screen is diffuse. There's diffuse atheroma, often no clear landing zone, and likely small increase in blood flow after putting a lot of stent in. The one on the right is a patient with more focal lesions. You can see there's 2 or 3 step-ups there. If you implant stents here, you're likely to have a large increase in blood flow. So you can see using physiology, you've taken those angiograms, which look very diffuse and horribly diseased, and you're actually able to dissect and differentiate between the two. So I think you're really able to transition here from saying it's just disease to actually a patients where you can say maybe sometimes it's better to leave this patient alone, even if they have positive physiology, based on the fact that PCI is likely to be unfavorable for that patient, and others where you see big step-ups where it's likely to be favorable. Now I'm going to share with you a case where I think that FFR is particularly limited in regards to making these assessments in serial lesions. So here this is a case from Carlo Di Mario, who Carlo's our chairman here today, which he presented recently in the course in London, whereby you see in this patient here there's a lot of disease in this vessel. Carlo makes measurements using FFR, firstly distal 0.74, then the mid vessel 0.91, and then proximal vessel 0.98. Now as we're taught, the best way of approaching this is to essentially look at the deltas. So you hear the big delta FFR of 0.17, proximal 0.07, and I think most of us agree that this is the place to stent, this is the place to treat. You expect a 0.17 increase, so expect that FFR to go from 0.74 to 0.91. So after the vessel was stented, we expected to go from 0.74 to 0.91. In actual fact, it went to 0.69. The rationale and reason for this is highly explainable by well-recognized physiology, and that's essentially that if you stent a lesion distal to another lesion, you increase blood flow down that vessel, and effectively it can cause the FFR value to either stay the same or drop. And this is a phenomenon of hyperemic physiology, well recognized. Then the measurements were repeated, another stent was implanted, ended up with a very, very good result at the end. But what it tells us is that from that initial pullback using hyperemic FFR, it's impossible to untangle which one of those two stenosis is contributing more. And also from that, you're unable to plan your PCI effectively up front. So you need to make repeated measurements, which often is very, very time-consuming and problematic. So FFR and serial lesion assessments, this is widely acknowledged. There's many publications in this area. It's not possible to independently interrogate tandem lesions. You need to average 3 to 5 beats. Now, what this means, practically speaking, and this is very relevant to co-registration, is you can't see the sudden changes when you go from a stenosis starting and stopping. Now, if I'm looking at a map and I want to see when things start and stop, I want to know. And if you're averaging over 3 to 5 beats, it blurs that over maybe 5 or 10 millimeters of vessel. Very, very important. It's not possible to visualize some stenosis at all if you have tandem or 3 lesions in a row, because the flow may be slowed to such an extent you don't have enough blood flow going across it to determine a pressure gradient. Here you can see such a case, lots of diffuse disease, pressure wire pullback is performed. You see using IFR clearly it's very significant, and you can see there's one step up, another step up, and another very big step up as you come back through this vessel. Now the same case here, but now it's performed using FFR. Again, both these values are very significant, no one would argue there. But now you can see these same lesions are impossible to detect distally, and when you come proximally through that very tight lesion, because of averaging, you see it's slurred over a few seconds rather than being discrete in terms of step-ups. And these are due to these phenomena I've described of inappropriate averaging, so 3 to 5 beats, and the interaction from one lesion to another. Now there's ways of correcting this using these complex formulas. No one I've ever met uses these. They're complex to use, they're time consuming, involves blowing up a balloon before you've even started, making a PCI, and just to make your interpretation. And it's limited to 2 stenoses in tandem. Now I'm just going to finish by showing you the rationale for this, and that this will hopefully lead on to the next talk, in terms of the difference between hyperemic or FFR-based assessment or resting-based assessment, iFR. Here you've got 2 tandem stenoses, 1, 2, and here you see the hyperemic flow curve going from no stenosis to severe grade stenosis, and you see the flow drops off hugely. If I then implant a stent distally here, there's no stenosis anymore in this vessel, and this effectively black measurement point now becomes red. So you can see how the flow increases as we relieve the stenosis on this curve. As a result, as you saw in Carlo's case, this results in the FFR staying the same or even going lower. If we do the same under resting physiology, because there's not a big drop-off in flow, you see this step-up is much smaller. Now this enables us, as we see from work from Nidja and more recent registry work, which has looked at larger patient populations, to accurately predict for the very first time the effects of treating one stenosis in the presence of diffuse or tandem stenosis, and this is very, very helpful for us to plan PCI, particularly in the era of co-registration. This is a co-registration image. Javier is going to talk more about this in a second, but this is to give you some introduction to this. So my conclusions are, using iFR, more patients are deferred revascularization with similar outcomes. Patients deferred using FFR have significant higher MACE in ACS than in those with stable coronary artery disease. Coronary artery disease assessment is not binary. Serial lesion assessment with FFR is not ideal. iFR makes serial lesion assessment simple, rapid, and easy. And I think iFR co-registration enables lesion detection and prediction within a vessel with diffuse disease. Thank you very much. Before I take any questions, if there are any questions, I'd just like to thank everyone on the panel and many people in the audience for the huge contribution to these studies. Manesh, as one of the chairmen for FLAIR, and his huge guidance. Patrick, for your guidance, and also, as Adrian said, Patrick's now, of course, said it's a huge challenge. You got 900 papers out of the Syntax 2, so with 2,500 from FLAIR, I think we've got a real challenge on our plate. Thanks very much.
So we are a little bit late before they throw us out of this place. I don't know if you have burning question. Well, thank you very much. Thank you, Justin. So Javier, stop chatting with Maria. Come to the floor. So the next speaker will be Javier Scanet, involved in all these trials and in all these developments, and he will speak about using iFR co-registration to predict and plan complex PCI.
Well, thank you very much for this. Of course, only a chairman who's been a friend for 35 years could tell me to come to the podium like this. It's 35, something like that. But anyway, so of course it's a great pleasure to share with you some of these new tools that we have to integrate all the physiological information that we have with the instruments that we have to use to take actions during our procedures, during our interventions. And I should start by saying that although the main use of physiology of iFR and FFR at this point is to establish if an stenosis is hemodynamically severe or not, you will see, I hope, in this presentation, that when you interrogate stenosis that are very severe, that you probably can know from the very beginning that they are very severe, you get relevant physiological information in terms of knowing what to do next. And I think that basically what Justin Davis presented up to now has been an excellent introduction to this technology that facilitates to us as interventionalists, as operators, to our decision making. So for that, I think that co-registration with angiography, as you will see, is a very powerful tool to integrate this information that you get there and to obtain your decision making. This is one case from our cath lab. This is performed routinely every day. The adoption has been tremendous. I mean, all my colleagues are using this because they find it so intuitive and so easy to use. So basically, as you could see, despite that you had here a rather severe stenosis, there is a pullback, and actually you can immediately see a pattern that resembles some of the patterns of pullbacks that Justin has shown us. In the past, what we did is, as soon as we saw this pattern, we will make some cine, so we could remember where the radiopaque sensor was, or the radiopaque segment of the wire was passing through, and then we could mentally link that particular segment as the one that is accounting for most of the hemodynamic impairment in the vessel. But as you will see now, now we don't have to do this. Basically, what we are doing now is integrating the information of the pullback with the last angiogram that was taken, and immediately, this is real time, you will get depiction in over the angiogram of the hemodynamic impact of all these different irregularities. And you can see clearly in this particular case that obviously that segment over there accounts for most of the hemodynamic impairment. Remember that the ambiguity, so to speak, of the hemodynamic, the functional relevance of stenosis applies to this segment or to this distal segment, etc., etc. It's true that this is, in this case, clearly more angiographically visible, but in other cases you get tremendous surprises. And also, as part of these tools, nowadays performing QCA is easier than ever. You can make very quickly measurements that are pretty reliable in terms of at least estimating which will be the initial stent size that you want to use, etc. Again, this is another, in the same patient, these measurements are done very quickly. The only time you have to spend is to make a slow pullback, but it's really, obviously, it really pays off because the information that you obtain later is absolutely phenomenal in terms of planning what you are going to do next. Again, in the right coronary artery, it was possible to see in this patient that the stenosis was severe. And here you can see that actually there are a couple of spots in the distal segment that have some hemodynamic relevance. There is an additional pullback that is being performed in this vessel because they wanted to reassure or to interrogate a proximal part of the segment, and this is what you are seeing there. One of the beauty of these systems is that you can actually do it as an operator. You don't have to ask the fellow to do any calculations or anything. You can simply manipulate the cursor with your joystick and select all these different steps that you are doing. You can see here that Nicola Ryan, one of our fellows, is actually doing this. She's manipulating the cursor, selecting in this particular case the angiographic view that she wants to use for this. So it really facilitates, it makes you much more independent when you are making these type of measurements. Now, I borrowed this slide from Justin because it's a way of linking also the two talks. He was telling us before that you have these different type of patterns, and of course it follows from this that the action will be completely different. And that's what I meant by understanding that despite that you may know that there is a significant stenosis in the vessel, you may decide or you will have to take completely different actions based on the the impact that obstructive disease has in the vessel, in the different locations of the vessel. And that led to the principle that perhaps it will be possible by subtracting these values that you obtain in certain parts of the vessel to perform what is called virtual iFR virtual PCI. That was the term that Suk Niger engineered or thought for this particular technique, by which you will be able to predict what is the final result of the intervention once that you have relieved the obstructive disease that is a particular segment. All these, of course, estimated from these pressure pullback curves with iFR. And actually, in this particular study, the results were very, say, encouraging in terms that you could fairly predict the final result based on your pre-PCI iFR measurements. So I'm going to show you how this has progressed since then. This is those are cases done in the last 2 weeks in my hospital. So using new technology that blends different modalities of the Philips technology. As you can see in this particular case with long diffuse disease of the LAD, we only have to make an injection now because we have dynamic road mapping. You can see there that I'm advancing the wire without any problem. It's a Berrata wire. I'm advancing the wire into the vessel. Of course, this offers immediately some degree of co-registration. You can see the location where your sensor is and to establish your measurement. This technology, you can apply it also to intracoronary imaging. You can move your cursor, your IBUS inside the vessel and make your observations. And here, as you can see, we performed a normal iFR measurement to start with. We demonstrated that there is functionally significant obstructive disease, but of course there are multiple irregularities, as you could notice. And now the point, the following point is what to do. And here comes the iFR co-registration that is taking place, again, in this case, with the possibility of understanding which segment of the vessel you are interrogating with the sensor. It's one of the beauties of this system. And building, again, the iFR pullback curve until you reach the tip of the catheter. The next thing that we will do, of course, in this particular situation is to co-register it with angiography using the same system that has been shown in the previous case. And by doing that, we obtain basically the distribution of iFR decrease or spots. Remember that each of these yellow dots is accounts for a drop of 0.01. So now you can calculate that, for example, if we treat this segment, we will have a final FFR of about 0.94, as you can see here, because you will add to the distal IFR 0.5. So we are just looking also to different alternatives, assessing the landing zone. This is, of course, you have to be realistic when you are treating this degree of disease, and you have to decide which segment you are going to treat according to not only to the physiological information, but also to the landing zone. Sometimes you have to use longer stents. In other cases, you have to do something different. And we treated the patient. You will see now the results in this immediately. We stented it actually with a long stent in this particular case. But what I wanted to show you is what is the final IFR after we performed this stenting of the lesion. Again, you are seeing, as you can see, we were calculating that it will be 0.94, and actually it's 0.93 after covering this segment of more than 40 millimeters. This is the final angiographic result. And as you can see, it's a really valuable instrument to really predict what is going to be the gain that you perform by stenting. It's really reliable. So, as conclusions, I believe that co-registration with angiography is a great technique that allows functional assessment and planning of physiology-guided interventions. The available results support the predictive power of pre-PCI calculation of IFR after stenting of specific coronary segments. And sorry for the typo here, dynamic road mapping contributes even further to correlating physiological findings with angiography-guided actions. This is something that is very important. It is quite likely that in the past we were rightly identifying a vessel that had a significant stenosis and wrongly stented the wrong place, and therefore not relieving angina or not relieving ischemia in the vessel that we wanted to treat. So thank you very much for your attention.
So this paper is open for discussion.
Yeah, I have some experience with the Sync Vision system using the co-registration. And from my experience, it is sometimes very difficult to discriminate diffuse lesion from focal lesions when the IFR far distal cutoff value is just, for example, 0.89. So we can see the only 11 dots along the coronary artery. So how do you think about, are there any tips to define such kind of the regional differences? For example, to make the hyperemic stimulus in these situations, we can find the many dots that may be easy to discriminate the lesion, focal and distal.
Yes, it's a very good suggestion, and of course it opens a whole line of research. I mean, obviously the development of the technique has been great enough to make possible that we apply this in clinical practice, but there are many multiple alternatives that are possible for this. We still need more research in comparing hyperemic pullbacks, even with, you see, with this technique and with FFR. I think that we still need to understand more about this. I think that's Justin before explained very clearly what are the physiological bases to understand why, when you're performing resting measurements, you should not be affected as much as when you're performing hyperemic measurements in terms of crosstalk between stenosis. But it is also true that one of the great advantages of interrogating with iFR is that you are you have a much higher spatial resolution. You are not using an average of pressures over 3 beats, which of course blurs the whole curve when you are making your pullback, and therefore this provides less crispy or less sharp curves when you are making the pullback. But I think that this is a very interesting topic, and obviously you see, it might be nice to see if there is any potential advantages for increasing resolution, as you say, if you use hyperemia in some cases, at the expense of perhaps increasing crosstalk between stenosis. Adrian, please.
I might share an anecdote with you about the value of using pressure wire to assess your result. So I did a case some years ago with a guy with an inferior STEMI who had an ostial LAD stenosis. I brought him back as to do the ostial LAD, and I was feeling conscientious, so I did an FFR. The FFR was 0.73, and I said to myself, I knew I needed to do it, so I put a stent in. I'd done it on the FFR wire, so I reconnected it, 0.75. That FFR wire was obviously rubbish, so I threw it away and I put a new one down, 0.75. So I threw that one away and got a third one, 0.75. So then I did the pullback. And of course the pullback showed me that the lesion was actually in the mid-vessel. There's a long segment of diffuse disease. And that little pinch that I put the stent in was completely clinically and physiologically irrelevant. And had I not done that, I would have wasted some money on the patient and probably put the patient at risk, because that stent was running into an area of significant stenosis. So I think I would encourage you to look at the FFR before the procedure, but I also use out your iFR or FFR after the procedure to be sure that you've done a good job. Because ultimately, it's very, very reassuring for you as the operator and the patient to be sure you have absolved the ischemia when you finish your procedure.
I think it's a great comment, and certainly cases that we all have struggled through and learned in that way. And I wonder, with the larger data set now, do you have any data on places where clinicians might be missing lesions because they have treated what they thought was the culprit, even in a stable patient angiographically, and there is a residual reduction in the physiology in that vessel?
So you're referring to DEFINE-FLAIR and SWEDEHEART.
Yeah.
Well, unfortunately, the study with the size it had, etc., there is no an analysis of every angiogram, and it was not pre-specified to do this type of analysis.
Yeah,
It's
so
really
hard to have the data.
To that type of study, you really need to pre-specified and really count with resources to perform this type of analysis. But this, of course, is a very important point. And on the other hand, I know that you are working with Justin and with Alan Jeremias in a study that is trying to identify actually what is the impact, or what is the impact of residual, say, iFR or functional iFR in the outcome of patients with PCI, which I think is an extremely important area. Yeah.
I think that, thank you very much, Gabriel. It was excellent, very well illustrated, very practical. So, Carlo is now going, as according to the tradition of EuroPCR, make the session evaluation and the key learning.
Thank you, Patrick. So I'm obviously somewhat biased by the fact I was one of the investigators of DEFINE-FLAIR. Patrick went through the history of all these techniques, didn't show the 3 objectives that we had for this session, and I want to remind them to you, The first was to learn about the primary outcomes from DEFINE-FLAIR and iFR-SWEDEHEART, and I think we did learn extremely well from both Gottberg and Justin Davis that we now have a patient-level meta-analysis that confirms and expands the results of the two individual trials, with iFR achieving the same outcome as FFR at 1 year in more than 4,500 patients with intermediate stenosis, where you really need this information, and reduces the need for interventions, sparing symptoms, sparing side effects, reducing the duration of the procedure. We saw also that deferring treatment in patients with ACS based on iFR seems to be safer than when you use FFR. This is what Dr. Davis has shown in his sub-study, sub-analysis of this cohort. The second objective was to learn how upcoming iFR studies will address physiology guidance in multivessel disease and entire vessel assessment. Well, I think we have to wait for that, because we did see definitely all the details of the design of the Syntax 2 trial, but we have to wait August when hopefully at ESC in Barcelona we will know whether a more appropriate lesion selected in multivessel disease using physiology and intravascular ultrasound guided implantation of third-generation drug-eluting stent can improve outcome compared with the historical Syntax 3-vessel disease cohort. This has used a little bit an old-fashioned physiology assessment with hybrid iFR, FFR, but again only 1/4 of those cases were affected by this technique. Majority of cases were done with iFR. Now we know we can do all of them. To learn how iFR co-registration simplifies complex coronary intervention, in my view, this is the most practical and also the most applicable of all the lessons that we have learned, because unlike FFR, iFR allows precise selection of the lesion and segments that you need to treat. So physiology becomes not just a tool to tell you, you have to do this vessel, you don't have to do this vessel, but to tell you precisely which lesion, which segment of the vessel needs to be treated and how to do it, and whether you have done a good job at the end of the day. I think this is the lesson that we have learned from these prominent speakers. Thank you very much to all the panelists for their contribution, and of course to Professor Serrais that started this all. Thank you.